Hi everyone, happy Antimicrobial Awareness Week. I'm Thursky, the Director of NCAS, and I'm not going to talk too much. I know I do talk too much, so we're going to jump straight into it. But before we start and before we listen to our first speaker, Jill, I'd like to do a welcome to country. As we gather for this meeting, wherever we are, let's take a moment to reflect the meaning of place, and doing so recognise the various traditional lands on which we do our business today. We acknowledge the elders, past, present and emerging of all the land we work and live on, and their ancestral spirits with gratitude and respect. So the first speaker today is Professor Jill Francis, who's really leading the implementation science movement in our precinct, and we're very fortunate to work quite closely with her, and I'm really excited to have Jill talk today. I think anyone who has heard her speak is always profoundly impacted by her messages, and so I'm sure that it's going to be another wonderful presentation. So Jill, over to you.
Thank you so much, Kaz, for such a lovely introduction. I'm just going to hide the panel here. And thank you to NCAS for this invitation today, and thanks to you all for taking the time to log in today. Hope it's a good use of your time. So I'm going to start us off in this session by looking at recent evidence about optimizing audit and feedback from implementation research. Now, so my, let me see. Okay, so it's for about 15 years, we've been thinking about better ways to deliver feedback to improve clinical practice. And I want to just draw your attention to this paper that was published in the first ever issue of Implementation Science, the BMC journal, back in 2006, when a Canadian consortium that I was involved in were first making the argument that we should be designing theoretically informed implementation interventions. And of course, audit and feedback is an implementation intervention or implementation strategy. And so one of the illustrations in the table in this paper was about feedback amongst all the different implementation interventions we might have. We were asking questions like what sort of content should we use, comparative, anonymous, how frequently or intensely should we deliver the feedback, how should it be delivered by post, peer, non-peer, duration of the audit process before that, and the context of the differences between primary care and secondary care. And we noted at the time that there's a ridiculous number, even if you just combine those questions, a ridiculous number of combinations that would need to be investigated before you could identify empirically some of the trends here. And the argument was that actually you need to filter all these ideas by looking at your theory of change. How do you think all of these things might impact on the outcome that we're interested in? And this is what's been done to a certain extent now by Noah Ivers, and I know you would have heard me talk about this Cochrane review before. Quite old now, back in 2012, but this was a meta-analysis of 140 randomised controlled trials that showed of audit and feedback interventions across a range of clinical areas that showed a median 4.3% improvement in practice. So it's effective, but look at how variable the effects are. An interquartile range approaching 0 up to approaching 20%. So much of that heterogeneity is still not understood. And so a few years later, another colleague from Canada, from Ottawa, Jamie Briot, led this work on looking at a range of theoretical positions on how best to provide feedback. And the argument was that guidance on providing more effective feedback does exist, but it's distributed across a wide range of disciplines and theoretical perspectives. And so Jamie and team did a wide range of interviews and surveys across a number of disciplines and came up with 15 suggestions for optimising effectiveness. These are only hypotheses, right? So the empirical work still needs to be done. And that's the inspiration for the first study that I'm going to describe today. So what's the problem? We know that in trying to establish and and make more effective the antimicrobial stewardship programs that we have, we usually use feedback as a part of that package. But we know that feedback is very variable in its effectiveness. We know that several features are associated with greater effects, for example, providing the feedback more than once. But there are so many potential ways of delivering feedback components. For example, which comparators, who delivers the feedback, and addressing all the components and combinations of components would require a prohibitive number of head-to-head trials. So theory is helpful for generating these hypotheses to focus the research. But of course, empirical methods are required to test those predictions. So today I'm going to discuss and present two illustrations of approaches that are theory-informed but have totally different methodological approaches. And the objective of these is to add to our body of knowledge about what works in feedback while doing as efficient a job as possible in terms of conducting the empirical research. So the first approach, led by Robbie Foy in the UK, the MOST approach, which is multi-phase optimization strategy, we'll talk about in a moment. And this is a study that's just come to a close in the UK. Then Noah Ivers in Canada from Toronto is involved in a couple of pragmatic trials, so full trials with theory-informed process evaluations. And this is particularly the one I wanted to talk about is a factorial design that compares 4 feedback elements. And again, this is a study conducted in Ontario, which is in process at the moment. So what I'm trying to do is to bring to you some very recent evidence, ongoing and recently completed studies about what makes good feedback, effective feedback in the antimicrobial stewardship space. So this first approach of using multi-phase optimization strategy was proposed some years ago by Linda Collins in the USA, a brilliant woman who's used this approach, which is used quite often in engineering to design, to invent new products. And her argument is, in the design of an implementation intervention, we can use the same approach, which involves 3 phases: preparation, so conceptualizing and piloting the intervention components. This is largely about theorizing how they might work. Optimization, which is randomized studies to identify the most promising single or combined intervention components. And so those first 2 phases were operationalised in the study that I'm going to describe now. And of course, they're much, much more efficient and less expensive than a full randomised trial to assess intervention effectiveness. So that's the efficiency argument here. So I'm part of a very large team based in the UK, led by Robbie Foy, who has conducted this randomised fractional factorial screening experiment to predict the effective features of audit and feedback, known as the ENACT study, Enhancing National Clinical Audit and Feedback. So this is across a range of clinical fields. It's not just in AMS, but I think the learnings from these different audit processes and feedback processes can be applied in the antimicrobial stewardship space. So just looking back to the very early, and I know there have been 2 updates of this, but this is the very early framework developed by the UK MRC for designing and evaluating complex interventions. And of course, audit and feedback interventions are complex. And I like this version of the framework because it speaks to the trialist. You can see across the bottom there the phases of clinical trials that we all know and love. And what this group did was to extrapolate from these phases what that would mean in the context of the development and evaluation of a complex intervention. And you'll note that what is called phase 1 here involves identifying the components of the intervention, so thinking components of feedback, and the underlying mechanisms by which they will influence the outcomes that we're interested in. So this is really Linda Collins' second phase, conceptualising and piloting the components of the intervention. And it focuses on the underlying mechanisms. The reason I think the underlying mechanisms are really important is that they define and inform the measurement strategy. So yes, we could use our strategies in AMS and then wait for embedding period, and 6 months later or a year later, we could look at whether clinical practice has changed. But if we understand the underlying mechanism, we can very quickly and very cheaply measure a proxy outcome, which is the underlying mechanism. Let me illustrate this. So here's the schematic of what we're interested in for any complex intervention. We have an outcome of interest and we have an intervention, but if we understand how that intervention works, then we've got some idea of what that measurable mechanism is. I quite often like to use the analogy of drugs and vaccines to make this point. So let's talk about vaccines for a moment. We know that the outcome of interest is protection from an infectious disease, but we understand that a major, not the only, but a major measurable mechanism by which a vaccine will give us that outcome is the immune response. And of course, it's measurable, it can be measured much more cheaply and much more quickly than the outcome of interest. And so we know very well in the last year and a half that the vaccine development process has involved measurement of an antibody response. Not that that's a guarantee that it will lead to our outcome of interest, but if there's no antibody response, if there's no immune response, then it's highly unlikely that our vaccine will lead to the outcome of interest. And that's really what I mean when I say let's theorise the effect of our intervention. So using that as the analogy, what we're interested in antimicrobial stewardship is practice change. We want people to change their prescribing behaviour, and we're using feedback to try to achieve that. Now, it's not rocket science, but it was in the 1960s that behavioural psychologists started to propose that if you want to understand, if you want to predict somebody's change of behaviour, you could ask them what they intend to do. As I say, not rocket science, but it's a measurable interim mechanism. It's very easy to measure, very quick to measure, very cheap to measure. And if our feedback doesn't even change people's intention to prescribe differently, it's highly unlikely that they will prescribe differently at the end of the day. So in this way, we can use intention. This is the ENACT project used intention as this measurable mechanism, the proxy outcome, to show us whether there is any promise in some of our feedback strategies. Now, of course, this whole pathway relies on our understanding the relationship between the measurable mechanism and the outcome of interest. So we know quite a lot about the relationship between an immune response and protection from an infectious disease. We also know quite a lot about the relationship between self-reported intention and practice change. So we know that on the left, Pascal Sheeran, who's Irish, now working in the USA, was leading some work on what is this relationship between intention as measured and behaviour. And then Martin Eccles in the UK and I were involved in a systematic review where we said, well, how does this apply to clinical behaviours? Do self-reported intentions predict clinicians' behaviour? We understand quite a lot about that, beyond the scope of today's presentation to talk about that, but roughly speaking, about half the people who report a strong intention to do something will actually do it. So it's no guarantee, but it's quite a good indicator of whether we're on the right track or not. So back to the ENACT project. The aim was to improve patient care by optimising the content, format and delivery of feedback from national clinical audits. And we were using this optimisation approach of using randomised studies to identify the most promising intervention components. So in our screening experiment, we worked with a digital health team and programmers to design iteratively some feedback modifications for testing using consensus and user testing methods. We used online randomisation of healthcare staff in those national audits to different combinations of feedback modifications. We measured intended enactment, our proxy measure, comprehension, user experience and engagement, and then we were trying to identify the likely winners or winning combinations of feedback that might have the greatest effect. Here are our 5 national audit programs. There was blood transfusion, trauma audit, there was pediatric intensive care, diabetes and myocardial ischemia. Sorry, there wasn't antimicrobial stewardship, but I think the learning is applicable here. This is just to give you a flavour of the screens that people went through. This is the welcome screen. This is selecting audit role, organisation type, audit role and organisation type, which then determined the kind of randomisation that was happening using an algorithm in the background. So we selected 6 interventions, 6 modifications rather, with just 2 levels of each, on or off, based on and developed from these 15 suggestions for optimising effectiveness. Here are the 15 suggestions, and the 5 bolded ones of those are the ones that we operationalised in this study. Recommend specific actions, choose comparators that reinforce the desired behaviour change, provide feedback in more than one way, minimise extraneous cognitive load, provide short, actionable messages followed by optional detail. And we decided, given the ethos of implementation research at the moment, to add one, incorporate the patient voice. Quickly, to give you a flavour of what these look like, here's providing feedback in text and graph. Here's an example of choosing a comparator that reinforces the desired behaviour change. If you compare current practice of 86% with a median of 79%, then the recipient is likely to say, oh, we're doing quite well, we don't need to change. Here we have a comparison with the top quarter of practices who are doing much better than the recipient. The recipient might well say, well, actually, we need to change our practice. So these comparators were what we were testing in this modification. Recommend specific actions, and so you can see the 3 tick boxes there with very specific actions. Provide short, actionable messages with optional detail, and you can see on the left-hand side of the screen, you could click to read some optional detail. And here's an incorporation of the patient voice, a patient story that we would hope would motivate people to change their prescribing practice. The outcome measures, intentions, and user experience. We have quite a detailed statistical design here, and you can see we were aiming for over 500 participants, and we did the power calculations and so on. And this is a look at our fractional factorial design. It actually wasn't feasible to use every combination of these 6 because some of them were effectively opposing one another. So we did that fractional design quite systematically. And a very quick look at the patient participant characteristics. You can see we had a range of staff, clinical staff, managers, and audit staff, and admin staff. And here's just a sense of the type of findings that we identified. In this particular example, there was an interaction between role, the person's job role, and the particular audit that we were involved in. For example, the clinicians, you can see in the PICANET, the Pediatric Intensive Care audit, clinicians had much higher intended enactment than non-clinical staff, but that wasn't the case for all the audits. The key findings from this were that none of the 6 feedback modifications independently increased intention to enact the audit standards, but they were potentially important, not only synergistic, but also antagonistic interaction effects. Quite important. The dominant influences were audit program and recipient role. We've got some limitations. We don't know anything about dose of this intervention. Of course, we have to question intention as primary outcome. This was a self-selected sample. There may have been duplicative responses, but we had an efficient evaluation of multiple features of feedback interventions. So that's our ENACT project. And there are some specific implications if we look at specific findings from this work. It might be worth incorporating patient voice. There's lots of quite complex implications, but the most important implication is don't just assume additive effects between the different combinations and different techniques that you might add to your feedback. So it is not the case that adding more bells and whistles to your feedback is going to make it more effective. I think that is the major message for today. Okay, this manuscript is currently under review. So you heard it first here on National Antimicrobial Awareness Week. These findings aren't out yet, but currently under review. Okay, for a second, and I'm going to go quite quickly through this second approach, which is to use pragmatic randomised designs out there in the real world in the context of clinical care. And this is much more specific to antimicrobial stewardship and antibiotic prescribing. So this a study that was published in 2021, in July of this year, and you will see there that Karin Schwartz was the lead author here, looking at the effect of antibiotic prescribing feedback. And the distinctive thing about this work is that we were targeting high volume prescribers. So this did not go, this is again back in Canada, in Ontario, this did not go to all primary care prescribers, only the high prescribers. And so this is, again, a way of maybe doing a work that's a little bit more efficient. And I think NCAS has looked at this approach as well. The key points from this work is that it was a very straightforward, very cheap intervention, a single mailed peer comparison letter, and sent to 3,500 primary care physicians in Ontario. And the bottom line is that just that one letter achieved a statistically significant 4.8% relative reduction in antibiotic use. So targeted messaging and, as I say, targeted to high prescribers. So here's the example of one component of the peer comparison letter. And you can see on the left-hand side of the screen, it points out, right at the top, points out that 80% of your peers last year, in practices that were very similar to yours, prescribed fewer antibiotics. So we know that that quite often clinicians will say, yes, but my patient profile is different. I've got a different lot of patients in my practice, and therefore my statistics are not comparable. So this group actually did those statistical adjustments and made sure that recipients were aware of that. The other component is, and again, this is consistent with one of the 15 suggestions for optimizing feedback, choose comparators that reinforce the desired behaviour change. So your personal data, you're prescribing many more than either the average prescriber or the achievable target, which we think would be a reasonable target for you. So there's a picture of what was in this letter. So again, featuring some of those components that were tested in the ENACT project, but this we do have the finding out there in clinical practice that it did make a difference, and it was a relatively cheap intervention. Noah Ivers in Toronto is also leading another randomised trial. This time it's a 2 by 2 by 2 by 2 factorial trial where there are 2 levels of each of these features: comparators, consequences, emphasis on antibiotic-associated harms versus lack of benefit, Substitute action. So people often say, if you're going to tell me not to do something, I've got to do something. How can I care for the patient by not doing something? And here's a possible alternative action, which is a shared decision tool that you go through with the patient and the clinician together come to the conclusion that actually an antibiotic prescription is not the best way forward. And then another potential improvement is a repeat letter at 1 month, so that kind of reminder system. So that trial is currently underway, but importantly, and led by Jennifer Trubiano in Toronto, linked theory-based process evaluation in which we're trying to understand what are those potential mechanisms and targeting some theoretical constructs. You can see there intention, self-efficacy, outcome expectancy, some technical names, because we're still exploring that mechanism of effect between the intervention and the outcome that we're interested in. And also looking at patient perspectives on the interactions with physicians who have received the feedback letter. Again, a lot of GPs say to us, but patients don't like it if I don't prescribe them an antibiotic. So we need the empirical evidence around that so that we can correct that impression if it's a misunderstanding. So just very quickly then, I realise I'm out of time. So the take-home message is there are still many uncertainties, more empirical research is needed. There's a possibility of greater impact by optimising features of feedback, and we still need to keep working on evidence around those. But it helps us to understand the underlying mechanisms of effect, partly because it helps us to optimise the interventions, but partly because it allows us very efficiently to evaluate and maybe reject interventions or feedback modifications that aren't likely to be effective. And also we can fold pragmatic randomised evaluations into existing feedback processes. And I know that NCAS is very interested in that and doing some of that work already. So that's the end for me. Thank you very much for your attention, and I'll hand back to Kaz.
Thanks, Jill. We do have a few minutes for questions. Can I ask the questions straight up, just in terms of the amount of effort we all do in terms of feeding back results? I'm sure many people on the call today spend hours formulating the way they're going to feed back their reports. How important is the visual representation, and was there a co-design process for this for the ENAC study on the optimal ways to visually represent data?
Yes, yes. I'll take the second of those first. There was a very, very intensive co-design process. So I used to work at City University of London, and our digital and co-design team was focused there and did a huge amount of work, not only in terms of the verbal content, but the visualization. In fact, we had a whole research fellow working on the visualization component, someone else working on the back end of this design. And that research fellow was appointed because she was very experienced in graphic design. And so not only did we have the expertise, but we had the iterative process of user-centered design that you would hope any digital intervention would have. And then, of course, whether that visualization is important is the empirical question. And from what we know from the evidence we've got so far, it's quite important to have two types of feedback: verbal and visual. And I think that could be because people vary in their capacity to process verbal versus visual information. And it may be that if we did some stratification of people based on their processing capacity, cognitive processing capacity, that we could target the visualization versus the verbal. That's still way, that level of stratification is way more sophisticated than anyone has done, I think, at the moment. But it's a great question. People like it, but whether it actually influences their practice is still an empirical question. I think we haven't quite finished dealing with the evidence around that.
Thanks, Jill. I'm sorry, all of us would probably like to pepper Jill with questions, but I'm just conscious of all the speakers that are coming up. So Jill, thank you so much. I think there is a huge amount to learn. Sajal, just one last question. Thanks, Sajal. Language. You know, a lot of what we do is actually in the English language, of course.
Yes.
How do we deal with this?
Multiple languages.
Yeah.
Now that we've got a sort of a multilingual, multi-ethnic healthcare workforce, this is a fabulous question. And I don't know of any studies that have looked at that, actually. So what a great question. Of course, any fuss around a screen, if we're doing this on screen, is going to be extra cognitive load. So this would have to be very well targeted and would have to cover the initial screen. So which language do you prefer? Great question. I don't think it's ever been done. I think it would be very expensive, but it's certainly something to explore for the future. Thanks for the question.
There is a question from Lisa Hall in the chat, Jill, if you're happy to have a look at that in the Q&A session, but we'll move on to Jason Trubiano, who is our next speaker. Thanks, Jason, for talking today. I specifically asked him to talk about how we go about measuring allergy, particularly in an EMR environment, and as we move forward, because as you know, the clinical care standards are going to be requiring it. So let's go to Jace.
Thanks, Kaz.
Okay.
You made me do new slides, so I'll thank you very much for that.
Oh,
Yeah.
sorry.
No, it's good. It's good. Thank you very much, NCAS and Kaz, for the opportunity to speak. So today I'm going to be talking about how we optimize antibiotic allergy via documentation, and actually having to do this, I put out a few case scenarios that I'm sure each person has come across. Just as a quick, why do we address it? Well, I often say this, but it's common. This is NCAS data. 1 in 5 Australian patients report an antibiotic allergy, and more evolving data nationally, internationally, that antibiotic allergy is associated with poor outcomes across a range of health endpoints, which are listed there. And they're fake news. More than 85% of them are actually negative on testing. And as Kaz mentioned, it's even sharper focus now. And I promise this was not pushed by myself, although I'm very happy it is now part of Standard 3, that antibiotic allergy assessment is part of our accreditation standards and how we approach that and embed within AMS. So some case examples. The first one is how, and I've pulled these from our antibiotic allergy round that we do every Wednesday, which is pharmacist-led, to give an idea of some scenarios where we can use documentation for action. The first is a patient that was prescribed both clindamycin and ceftriaxone, both of which were inappropriate because of a penicillin allergy. This caused an automatic alert via our SIR embedded system, which I'll describe in a minute, led to an assessment by our allergy pharmacist on the Wednesday round, clearly confirming this was a communication error, and on confirmation with the GP, the patient had no antibiotic allergies. This led to an action where penicillin allergy was removed and prescribing was averted back to normal guideline-approved prescribing. And this concept of alert, assess, and action, I think really can be embedded in the way we approach EMR and documentation. No point just working out a system to assess. There has to be some endpoint or action point to that. Case 2 is very similar. Patient prescribed ceftriaxone, but flucloxacillin with a penicillin allergy. An alert was triggered, penicillin allergy receiving restricted antibiotic. An assessment was performed based on the ideas of reaction, severity, and the substance. Confirmed it was a type A adverse drug reaction, diarrhea, and the action was removal of that allergy, consultation with the patient, letter provided, and allergy label removed. And I think this is, again, an evidence where without any fancy testing, just direct delabeling via a correct documentation assessment. And the third is before we had any antibiotic allergy programs at the Austin. This was a disturbing case of a patient that presented with hematuria. The wife, as you can see listed here, says unsure name of drug. The patient received trimethoprim for a UTI, developed a rash the next day and re-presented to hospital. And you can see across the time of their admission that eventually that rash was actually found to be Stevens-Johnson syndrome. The patient had a previous episode of Stevens-Johnson syndrome at another hospital, and this is a disconnect between our medical records not talking to each other and not performing an assessment, and the patient had a 67-day stay in hospital due to an avoidable error. And we missed the alert here, we missed the opportunity to assess, and we missed the opportunity for action. So I think good antimicrobial allergy documentation is good AMS and medication safety. And we don't need any fancy testing to do these basics and probably achieve what the accreditation standards want us to achieve. If we put it in context, this is an overarching schematic of our antibiotic allergy program that was launched at the Austin and Peter Mac back in 2019 and is now embedded in practice, where a patient is admitted, discovered, reported a penicillin allergy. An antibiotic allergy assessment is performed using this tool, and people categorized into low, moderate, and high risk. And I've highlighted here that the opportunities for documentation and EMR implementation are at these points here, both at the assessment by a pharmacist and nurse in particular, and also then digitalization of this assessment tool into the EMR. So nursing engagement is clearly leading to improved documentation. And our early work done with VicTag was actually a pilot program where we developed an Atlas learning module, an assessment tool, a toolkit to teach nurses to perform antibiotic allergy assessment at point of care based on the concept of severity, timing, and tolerance. When we implemented this on hematology wards at Austin and Peter Mac, we had good completion and uptake, and we saw an immediate increase in the accuracy of which the allergy was reported in the EMR. And you can see from those previous examples, if we have good EMR accuracy, we're going to have good AMS prescribing. We took that further during the allergy program with a range of materials that were developed for consumers, but also for healthcare providers, particularly nursing, to really showcase that nursing are central to antibiotic allergy assessment at point of care. When we did this, we saw a 52% increase in the allergy record being complete, containing at least the drug name, the severity, and the description. I think they're three key things that should be standards of care in all allergy records. The other one is pharmacy engagement. This was a paper by Misha Devchan, which again now continues in practice at our hospital, where a weekly ward round is performed with a multidisciplinary team, where a patient is identified as receiving an antibiotic and a penicillin allergy. An assessment is made in consultation with the AMS and ID team and recommendations provided, and an action is provided all the way from direct delabeling, medical reconciliation to antibiotic advice and prescribing to testing. And I think we're going some way into making these a standard of care in the hospital. Again, all based upon documentation. And the final is EMR implementation. So we took this very busy color-coded assessment tool, which was great and initial in theory and has been adapted in the pediatric setting, actually in the New South Wales environment from Brendan and his group. But we've built that into an EMR tool in Cerner, really focusing on penicillin allergy due its biggest bang for buck, and condensing that words down to 3 boxes: mild, moderate, and severe. And this is required for all nursing admissions. A patient has their penicillin allergy performed, and if they are ticked as mild, an automatic referrals to the AMS team into a message center, and we act on that referral and go and see them for challenge. The alternative is also being built within Epic across the Parkville precinct, and particularly at Peter McMullen Cancer Centre, where there's a smart text or code that can be used to trigger an antibiotic allergy assessment to be performed. And then this is reviewed by our AMS nurse-led structure at Peter McMullen Cancer Centre. Again, this has led to a significant change in the EMR completion and assessment with the change to an EMR-based platform. And in the end, we should always link documents with action. I've highlighted this. So if we do these things and we embed assessment and documentation into practice, we'll be able to take, busy tables like this, but this is a nice, actually, summary table by Misha, and link a assessment with a direct oral challenge or direct delabeling. And as part of that program I talked about initially, we did 150 direct delabels, which is just removing the allergy based upon medical reconciliation. And even in people that had high-risk allergies because they'd actually tolerated the antibiotics previously. Performed more than 200 oral challenges, and in a sustainability paper just published now, almost 500 oral challenges with the same effectiveness. And we're also able to appropriately document high-risk allergies. And that last case I talked about is important because it's not just about delabeling, it's about labeling and getting those severe phenotypes correct as well. So pathways for improved documentation in the future, I think, are based upon these 4 things. Building assessment into practice, but then translating that to EMR. Translating the EMR into automatic referrals to our AMS system, and then overlaying that with tools that we develop along the way. Something called PITFALLS, which is an assessment tool we've done, and there is the prototype of a smartphone app where we build all of this at point of care. We can now do this because we're mandated to do it, or we can move towards it via our standards, and hopefully we're going to be able to launch these programs both locally in Victoria, but also via the National Antibiotic Allergy Network to try and utilise this sort of toolkit that we've developed now based upon documentation and embed in practice nationally. So thank you very much to everybody that's really enabled this work, and happy to take questions on the side via the chat.
Thanks, Jake. I think it just outlines why we need to be really mindful of everything we do in terms of documentation needs to be related to an action. I think that's actually a really good principle. We're going to do questions at the end just because I'm mindful of the number of people that are going to be talking. So we're going to jump straight to Brendan McMullen, who completed his PhD in Pediatric Antimicrobial Stewardship. And I specifically asked him to talk about how he was wrangling some statewide data, just because I think many of us have the opportunity to do it these days, and we want to hear how you went.
Thanks very much, Kaz. My PhD primary supervisor extraordinaire. Can everyone, Kaz, you can see my screen okay?
Perfect, yep.
Great, okay. So yes, I'm going to be talking a little bit about some statewide data on paediatric infections. And here are my disclosures and a couple of affiliations. Essentially, I'll try and persuade you that there is a big problem with infections in little people, but as many of our presenters and audience will be aware here, it's one thing to have a bunch of data and it's another thing to make sense of it. So we're drowning in data, but sometimes information poor. The statewide data set we've used is one of administrative data based on activity-based management. So I'll talk about how we're converting dollar figures into cents, and then I'll kind of give you my clinician's take on what this all means and what we can do with this information. So you'll probably be aware that recently there was actually a 4th Australian Atlas of Healthcare Variation published, but the previous edition published in 2018 had a particular section that focused on paediatrics and neonatal care. And from that data set, it was revealed that for children up to the age of 9 years, there was an average rate of antibiotic prescription of at least 1 per year, so 1 per child per year, but there was substantial variation in the quantity of prescribing, so almost 17-fold variation. And of course, that PBS data doesn't give us any indication of the quality of prescribing. But you can see here graphically by local area, by the area of residence of the child, there is a bell curve, but there is a huge variation in the dispensing rate per population. Qualitatively, we do have access to some other data sets. So as part of my PhD work, I looked at the National Anti-Microbial Prescribing Survey, or NAPS, data for children. So I took a 4-year sample. I looked at over 6,000 prescriptions in almost 4,000 children and assessed the type and quantity and quality of prescribing to children in hospital that participated in NAPS surveys from all around the country. Now, in that data set, community-acquired pneumonia and sepsis were 2 of the top 5 indications with antimicrobial prescribing, alongside other things like surgical antimicrobial prophylaxis. But for these common infections, there was again great variability in quality and in the type of prescribing. So community-acquired pneumonia prescribing was judged to be inappropriate by the assessors in 1 in 4 cases, which is obviously much higher than we would like, or that we as a country should put up with. And risk factors for inappropriate prescribing were non-uniform and were systematically different based on really probably resource provision. So there was less appropriate prescribing in non-tertiary paediatric settings and less appropriate prescribing in non-metropolitan locations. And appropriateness also varied quite a lot by the specific indication, whether that was a type of infection or a type of prophylaxis, and by the prescriber group, so the specialty group that was doing the prescribing. Now, that NAPS data, while being the first kind of comprehensive analysis of the quality of prescribing around the country for Australian children, is really only the tip of the iceberg. So 6,000 prescriptions over 4 years is a tiny fraction of the amount of prescribing to children in hospital. But up until now, it's been hard to kind of get that information on exactly what is the burden of these infections in Australian hospitals for children. So the next step, and what we did about that, was turning to New South Wales data, that's where I work, to activity-based management data set. So activity-based management is used in New South Wales as an administrative data set that is made available to managers and clinicians of our area health services, which are called local health districts, or LHDs. And this information has all of the features you see here. So it's designed for analysis, for performance improvement, for benchmarking, for improving resource use, and it includes selected information on clinical documentation, clinical coding, financial coding and costing information, and is designed in such a way that you can do some reports directly in the activity-based management portal, but you can also export data to do further analysis with more sophisticated statistics or targeted reporting. Here is an example of what one of the fields look like if you are doing a particular report. So I'm not sure how well this projects for you, but you can see that you can essentially stratify your reporting by the age. So for example, you might want to look at elderly people over a certain age, or children in my case. And then you can get information on principal diagnosis, principal procedure, as well as a whole bunch of activity metrics such as inpatient length of stay, bed days, and then cost metrics like average cost, total cost, variance, and a number of other analyses depending on your area of interest. So we took, for this particular project, a look at some common and or important pediatric infections. These infection groups are relatively serious or relatively common and are well known to all pediatricians and child health providers, and are an important cause of infection and morbidity, often leading to hospitalisation in children, with the exception of UTI, which rarely leads to hospitalisation, but certainly does at the severe end and in the very young infant. And using this activity-based management data set, we were able to show that the burden of these diseases was substantial in terms of cost, as well as the number of bed days. I'm only presenting for you here an example of the costing data for these 10 infectious syndromes. But what you can see even here is that pneumonia and appendicitis, far and away, are the most costly infections out of this 10 group of infections. And I should say that this data set, we looked over 3 years, 3 financial years prior to COVID, among nearly 350,000 paediatric admissions, which included everything from stay in hospital from being born to coming in with a broken leg. Almost 30,000 of these, so almost 9%, were with one of these 10 infections. As a group, these 10 infections accounted for over $230 million in healthcare funding, the median bed days were 3 days, but there was a great variation depending on the type of infection, as well as the location of care. So as I said, substantial cost, substantial variation in length of stay and cost by condition. So the other thing we discovered was that 80% of children with these infections were admitted to a non-paediatric hospital, and that Indigenous children were overrepresented compared to population, but paradoxically had a lower length of stay on average and a lower cost. So I've only presented a small amount of the data from this particular analysis, and we are submitting this for publication with a whole bunch more implications covered. But I think the next steps from this information is we need to use this to prioritize quality improvement. So this actually gives us information to help target paediatric policy and programs. We need to determine whether reducing these days in hospital by improving care and facilitating discharge home sooner, when safe to do so, genuinely translates to savings for the healthcare system, but also qualitative benefits, patient-centered benefits for children and families. And I think going beyond that, we need to be building patient-centered outcomes into AMS programs, following on the example that Kaz has presented at previous Antimicrobial Awareness Week meetings, as have some of our other speakers. We need to get out of talking to ourselves and start talking to our colleagues, to our patients and consumers, and to policymakers. And I'd like to acknowledge Kaz, as well as Lisa Hall and Jake Valentine, for contributing to this study. Thanks.
Thanks, Brendan. Up next is Mignon Avent. Queensland has been very innovative in some of their statewide work, so I really look forward to hearing that you talk today about your paediatric program. We can't hear you yet though, Mignon. Still can't hear you.
Hi everybody, can you hear me and see my screen now?
Just perfect.
Okay, thank you very much for inviting me here today. And this talk really lends itself nicely to Brendan's talk, which he really set the scene quite clearly about AMS programs. And we've focused on an intervention, a low-hanging fruit for rural and regional areas, focusing on IV to oral conversion. So it was, we received funding for it, and it was conducted by a number of people across the representation across UQ and OSHI, as well as Queensland Health. Okay, so as Brendan outlined so nicely, the reason why we focused in these areas is we know about a third of the children in remote facilities are less likely to receive the right antibiotic. We also know that 1 out of 2 children in hospitals are on an antibiotic at any time period. And the reasons for the inappropriate prescribing really are multifactorial, looking at antibiotic spectrum, inappropriate route, as well as longer courses of antibiotics. And it really highlights the lack of resources and education for these facilities. So how do rural remote facilities differ to more metropolitan facilities? And really, basically, what they need in the rural or remote areas is they just need some help here and a bit of direction. And we've been able to get some really great engagement with our rural regional facilities. And this was from one of our HHSs. I thought I'd be able to see the Melbourne Cup running this year, but they were so engaged in our AMS ward rounds that we all got to miss Melbourne Cup due to the engagement that we received. So as a bit of background, Brendan's published a very nice study, and his team looking at a team-based approach to IV to oral switch in a metropolitan. And what they were able to show that by early and appropriate switches, you will be able to reduce the length of hospital stay, and it really tied quite nicely with the decrease in IV duration of antibiotics as well. So as I said, we did get funding for this, and we worked collaboratively with a number of groups. So we were looking at the timely IV to oral conversion, and we were hoping to show that we could reduce length of hospital stay, and we were also looking at some indicators to optimize quality use of medicine for antibiotics. We were able to enroll 7 sites, and none of these sites were metropolitan, but they all had a pediatric ward in their facility. We had 3 phases to the study. Our baseline phase was really to interview and meet with clinicians to find out what they would like and how we could tailor resources to meet their needs. We also included patients and, well, the parents and caregivers, and we also tried to reach out to the Aboriginal Torres Strait Islanders as well, but we ended up using the liaison healthcare workers that work quite closely with these patients. We had an intervention phase, and then we did our post-implementation phase. So we ran our baseline phase and our intervention phase for over 7 months using the same time period in the previous year to avoid seasonal variation. And we focused on the 2 common infections, as Brendan's outlined, in these areas, which is community-acquired pneumonia and skin and soft tissue infections. And really what we were looking at is patients that were pretty stable before they were switched. So we had a multitude of resources, both for the healthcare workers and for the parents and caregivers as well. We also developed additional resources, and we had a yarn, a patient education video. We allowed the sites to choose where they would like to, how they would like to use their resources and who wanted to use them. So that was one of the strengths of the study. We were able to enroll about 178 patients in the baseline and 179. We were able to show that the mean age was comparable between the 2, and we had slightly more patients in pneumonia than skin and soft tissue infection. What we did show was, because they have such short lengths of stay in these areas, that we weren't able to decrease the length of stay, but we were able to show a decrease in line-associated infiltrates as a complication. We looked at length of stay to see which factors would impact it, and we associated the line-associated infiltrates, inappropriate switches, and inappropriate IV antibiotics were all associated with an increased length of stay. As far as timely switch goes, we were able to show an improvement as well as a decrease in extra days of IV antibiotics. And then it can be seen quite nicely in this graph where patients switched more appropriately when you looked at day 0, which is when they were supposed to have switched. We also looked at compliance and appropriateness of prescriptions, which is a sort of an added effect to this study. And unfortunately, despite having multiple interventions and multiple interactions with the prescribers and the clinicians working in these areas, we really didn't show a great improvement in appropriateness. This study also included economic analysis, and what we were able to show by modeling it is the willingness to pay threshold, which is here on the x-axis. We were able to show that there was about a 50% cost effectiveness acceptability curve. And working with Mick Graves' group out of OSHI, that's sort of the mark that they suggest, that if you have a willingness threshold to pay, a probability cost effectiveness about 50%, the intervention is really worth doing, as opposed to doing nothing or using the current state of play. As far as the impact of materials, so we did have interviews afterwards to see what worked and what didn't work. So they particularly liked the design of the materials. I think what's really important is to find out what the juniors like and how they use them. And it certainly facilitated discussion with the more senior staff, helped with the training, and they felt empowered to make decisions and recommendations. The barriers were, it was hard to engage with the senior clinicians, and in many cases, these clinicians spend a lot of time in the clinics. They have consultants flying in, and so not always a consistent staff. Unfortunately, in the wards, they didn't have a consistent pharmacy presence, and we've already mentioned the high staff turnover rate. So really, the scalability is we would like to expand this to other facilities in Queensland and build it into the statewide antimicrobial stewardship program, where we have a pediatric component. Currently, our focus is on adults. So with any intervention and program like this, there's a multitude of people that are part of it, and particularly I'd like to acknowledge the clinicians on the ground who provide us such great support and encouragement. So thank you, everybody.
Thanks, Mignon. Incredible. And I guess that segues extremely well into our next speaker. I always enjoy listening to Teresa Wozniak. So she's going to be talking to us about disease surveillance to capture social drivers of antimicrobial resistance. So welcome, Teresa.
Hi, I'm just having some trouble with sharing for some reason. I'm not sure why.
You can jump to Brian if it's easier.
Yeah, I might have to send this maybe to send my presentation across to Arjun.
Sure. Brian, are you happy to jump on next?
Sorry about that.
Yeah.
Sure, no worries.
Thanks, Brian. Brian's one of our NCAS PhD fellows in the animal stream, looking at some more innovative ways to work with data. Welcome, Brian.
Thanks, Kaz. So my presentation was going to be a joint presentation between myself and Dr. Laura Hardefeld, but we decided, just given the time frame, I would just present the whole thing. So just bear with me on some of that stuff. But because it is a very collaborative effort on a lot of people's parts, and so we're applying big data to general practice and implementing our studies to create an antimicrobial stewardship program, as well as get to see like sort of the results from this program. So it's been really rewarding as myself as sort of a data scientist and a veterinarian, but to be able to work with this data and extract all this data, but actually get to see it get implemented to get used for in the field and see the outcomes. So as many of you know, obviously that, antimicrobial resistance is a real problem. Some people may be less aware that veterinarians actually contribute to antimicrobial resistance. And so, these antimicrobial stewardship programs that have been demonstrated to help combat antimicrobial resistance are useful not just for people, but also for veterinary practices as well. However, they do require data to inform these programs to show how they're effective and get baselines and then show how effective they are over time. And so we use a very interesting data set called VetCompass Australia, which has veterinary records from over 180 practices across Australia, has over 15 million clinical records inside of it. And then this 1.3 billion tokens, which is how much text is inside of it. If you're into natural language processing, there's just a lot of data that you can do interesting things with. So getting results from this data is it's not as straightforward as it might seem. The data is very noisy. It's mostly unstructured free text. There's a lot of useful information in it, but it's really difficult to get to sort of the meat of these issues. In our case, we're looking for which antimicrobials are being used, but sometimes there's no labels, or they're labeled as miscellaneous items. So it's not very straightforward just to look at this noisy data and extract the useful information out of it. So that's where natural language processing comes in. This is an area of computer science that uses artificial intelligence and looks at this interaction between computers and human languages to help us extract structured data out of unstructured text. In our case, we're looking for antimicrobials, and there's different approaches that can be used. You can create rules-based algorithms, if this, then this, or you can also apply, machine learning or deep learning neural networks, which is sort of where the newer research is focused on it. But there's still a good place for rules-based algorithms. And when we're looking to use natural language processing on it, well, there's still a lot of steps that we had to do to get things ready. So we had to create a dictionary of all the drugs that are used in veterinary medicine. As this wasn't readily available, we had to map all the drugs that were there to the ingredients that are assigned to these different drugs and medications, just so we had a gold standard, as well as understand the ratings of antimicrobials. So the Australian Strategic Advisory Group has a rating of low, medium, or high, just as their importance rating for leading to antimicrobial resistance. And then we created some rules to look through this VetCompass data. We tested a variety of different things, including rules-based and machine learning methods. And these were just the ratings where we had low, this traffic light sort of system, where green is the low importance, yellow is the medium, and red is the high importance for contributing to antimicrobial resistance. And then this is sort of what a prescription label might look like. And in order to do this, we had two veterinarians, myself and another veterinarian, actually Laura, we annotated 200 records to calculate, well, what is our gold standard for how well these algorithms work? And so we were able to find out, even though it seems really easy to label what medication is mapped to an ingredient, we actually, would disagree if you label the same set twice when you look at it. You just make mistakes when you're annotating things. And this is important when you look at how accurate anything is there's no such thing as a perfect gold standard. So when they say this beats human performance, well, human performance is often flawed with these things. So when we were testing how well we could extract antimicrobials, first we tested machine learning models as well as some deep learning models. And we did this by taking a subset of VetCompass data that just looked at all the antimicrobials in Victoria, and then we would use those to test to see how well things were working. So we just manually labeled those records so that way we knew if we were properly extracting the ingredients. And actually the best method that we had for getting the ingredients was a rules-based method, which was a combination of things rather than the deep learning methods, which had good accuracy. This one was just the best. And, as you can see, it had a higher accuracy actually than, what our agreement score was. And when you look at it, you could see that the algorithms were often correct, where labels were not, which again goes back to, it's really important to have good gold standards for when you're measuring how well the accuracy is on any of these big data studies. And essentially what we set up is we set this model up for Vet Compass so we could extract the item labels out, we could label the records with antimicrobials, then we could match those ingredients to those medications, and then map them to their appropriate ASTAG rating, and then we would import them back into Vet Compass. And then we reported this actually, there's a study in PLOS ONE where we reported our results, where we sort of look at, you know, how we can see the difference, and these are the clinics that are inside of it, and these are the average prescription rates that they were doing, and just to show that we had that ability to look at those things, and so we were starting to get good results for how we can look at the clinical level, and we could see overall just what's being used inside the Vet Compass data set when we looked at the subset that we were looking at of the millions of records overall. So that's where you know, the antimicrobial stewardship trials were sort of based on these to use this data and start inputting them in. And so there was a collection of Green Cross veterinary practices, which is Green Cross is a large veterinary practice group here in Australia. And there was a control group as well as Antimicrobial Stewardship Group 1, Antimicrobial Stewardship Group 2, and they all had, you know, the prescribing guidelines, posters, and educational webinars. And the AMS2 group just had, you know, everything, basically everything in the kitchen sink thrown at it. So looking at the results on how well those different groups worked and things was sort of the goal of this. And, you know, so we looked at this over a period of time for the implementation phase and then the post-implementation phase. And there was a survey completed by about half of the Green Cross vets. Antibiotic use in the 2 years before the trial was compared to the implementation and post-implementation periods. There's also a series of interviews of the vets, nurses, and practice managers, but that's still being analyzed. And so that's not going to be presented today. We were just looking at the quantitative data. And so during the trial, we had this, you know, the incident rate was about 2.4 per 100, and then post, it was about 1.9 per 100. So there was a decrease of about 47% from the pretrial phase. And the prescribing clinics enrolled was about 11% and 14%, looking at the implementation phase and the post-implementation phase. Just having everything included did show a significant decrease from the controls. The COVID-19 pandemic was going on during this phase, and we did note there was a 7% increase of the incident rate of prescribing during the pandemic. And so looking at, again, more into it, we can see that we look at overall the low, there's more to the story. So we can see that, you know, the incidence rates for low importance antimicrobials increased actually, which is good because we wanted to see them use those more focused antibiotics. And that increased from 12% to 20%, even though the overall rate of prescription was lower, they were using more low important antimicrobials. Medium importance also decreased from 74% to 50%. But importantly, the high importance, this was actually a little bit, you know, surprising, but went from 12% to 20%. So we actually had an increase in both the control and the AMS1 and AMS2, although not as much in the AMS, the antimicrobial stewardship groups as the control. There was still an increase of the high importance antimicrobials that were given during the study, even though the overall usage was down. So that was definitely an interesting finding for it. And also interesting was that the top practices that were in the top 25% pre-trial period actually reduced the most, like, of all the other practices. So the ones that were maybe higher on those rates actually decreased quite a bit. So that was another really good finding, just to show the effectiveness of these antimicrobial stewardship trials. And so overall, I just wanted to say, you know, using big data like Vet Compass and natural language processing can be leveraged, you know, to help these programs, and implementing these programs in veterinary practices was shown to actually be effective, which is great news. But we certainly want to do further work looking at benchmarking practices in a peer-to-peer sort of comparison, sort of to use some of that data, because we've also done NLP research on extracting the indication for use and other things at a big data level. And we'd like to be able to implement these things a little bit more. So thank you for your time, and also to my research group that's helped me do all these studies. And I'll take questions in the queue or after we're done with this session.
Brian, thank you. I think for everyone on screen, I would say that this was a beautiful example of what we would consider to be a learning health system. So congratulations on your work and the team's work. It's just, I remember at the very start and where you've come to is incredible. So I've actually I've got your presentation, Teresa. So I will share that.
Thank you. And I do apologize for that. And thanks, Brian, for jumping in. So thanks, Kaz, and thanks, NCAS as well. The work that I'll present today, and I suppose a lot of my thinking around AMR is the complexity of AMR really started when I lived and worked on Larrakia land in Northern Territory. So can we go back one? Sorry. So I'd like to acknowledge the traditional custodians of this land, past and present and future and emerging. And I've been actually attending this week the AMR Summit, and one of the things that really struck me, and I thought to perhaps bring it to this discussion as well, was innovation and how important, and what drives innovation, and how important lived experience is for innovation. And so I wanted to sort of weave that into this presentation a little bit, and wanted to take you to a remote clinic. That's perfect. Thanks, Kaz. Yep. So I wanted to take you to a remote clinic in Central Australia. You are a rural medical practitioner. You work in this small community clinic. You're one of the very few doctors there, about 500 kilometres away from Alice Springs Hospital and almost 1,000 to the Royal Darwin Hospital, which is the main tertiary centre there. Next, please. You have a patient that comes in to see you with what is quite a common condition in the NT, a skin infection. Clearly, there may be other issues that you would have to deal with, but for the purpose of brevity for this little case study, let's just say the skin infection is the most important one, that your most pressing issue that you would like to resolve. So you will probably take a swab sample and you will send it across to pathology. But because of where you are actually located, best case scenario will be about 3 days before you actually get the pathology results back, and when you can actually determine the causative organism. So I suppose you have to just return to the resources that you have. Next slide, please, to make the decision around what is the best clinical management for this patient. So you have the CARPA treatment guidelines, which are Central Australian guidelines that have been developed specifically for people, for health practitioners living and working in Northern Australia and remote clinics. You have your clinical expertise, which is clearly important. And now you also have this really great new tool that we've started to implement in primary health, which is a Hotspot Surveillance program that allows you to visualize AMR data by region, by age, and by sex. So based on this sort of resources that are available to you, you decide that antibiotic X is going to be the antibiotic that you will need to treat this patient with the skin infection. So you go to the clinic to find this antibiotic X, or you might have to go to the pathology, the regional pharmacy. Next, please. And when you arrive at the regional pharmacy or in your pathology, in your clinic, you find that actually we're out of the stock of that antibiotic. And this is actually quite a common case, that the antibiotics that are the most appropriate antibiotics and the right antibiotics to treat those patients aren't actually necessarily available at all these clinics. So the consequences of this are really significant. You know what is the best treatment, what is the most appropriate antibiotic to give them based on the evidence that you have, but you actually don't have access to that antibiotic. And the consequences, as you can imagine, are more than likely this patient will end up needing to be evacuated to one of the main hospitals. The patient will have to be removed from the community, so the impact is on the patient, hugely on the health service, with medical evacuation being very costly, and society more broadly. Next, please. So the point I was trying to make with this sort of lived experience, in a sense, is that really knowing the best treatment for that patient was still not enough for them to have had that antibiotic that they needed. And I suppose my experience with AMR in the regional and rural context has been that these patients live in this really complex social and economic context, and really we need to better understand that. And this is what drove this sort of study that I wanted to present to you today, which is, could we potentially repurpose surveillance that we do for pathology, phenotypic surveillance, to actually capture have a better understanding of what is driving these infections. Next, please. So we wanted to find out what are some of the other data sources at the population level that can better inform this AMR problem and improve the health outcomes for your patients. Next, please. We looked at the socioeconomic drivers, socioeconomic indexes that are published by the Australian Bureau of Statistics, because we were looking for something that was ongoing and something that was at a population level. So these are captured by census data, and the social disadvantage index, the first one we looked at, is an index of relative disadvantage, and it is measured by people living, the number of people that are living in low-income households, the number that are living without internet, families with young children who have parents that are unemployed, and the rate of unemployment. The other index was the access to health services, which is also known as the remoteness index. And the third one was the average person per household. Next, please. So that combined with, so we then overlaid this information on our Northern Australian picture that you can see there. So on the left, you can see the index of relative social economic disadvantage. Approximately 72% of our population living in this region, shaded in the different versions of blue, are in the immediate to most disadvantaged. When you look at the green, where you're looking at the remoteness index, about 80% of the population are living in what is considered by the ABS as remote or very remote. And lastly, the third index, which was the average person per household, the most purple is where it is the most considered to be the highest overcrowding. And so that region in the top of Northern Australia, of Northern Territory, is a region that has an average of 4.3 persons per household, which was a little bit surprising to me, because I do know that overcrowding is an issue, but clearly the way that these indexes are measured is important to consider, and I'll sort of bring that back towards the end of my, my presentation. Next, please. So the data set that we were going to overlay the socio-economic indexes with was this data set, which is part of the Hotspots program, and it is laboratory-based phenotypic surveillance data of resistant infections. We focused only on the primary health data. We had about 12 years of data and some of the key pathogens listed there. Next, please. And this is really to show you that what was actually surprising to me as well was actually the amount of geographical variation in AMR in this region. So you can see these pockets of clusters of hotspots, particularly for MRSA. You can see in far north WA, really high rates of MRSA compared to, for example, parts of far north Queensland, and equally so variation across Northern Australia in regards to third generation cephalosporin resistant E. coli. Next, please. So when we looked at the AMR data with the socioeconomic factors, we found that if we were residents that were living in the more remote areas had a significantly increased risk of MRSA and third generation cephalosporin, just those two. Next, please. Interestingly, we found no correlation between AMR and socioeconomic disadvantage, and we sort of really wanted to ask ourselves why that was. Next, please. So what we thought was, and like I said, this was an exploratory study that is currently being reviewed in a journal, but it really made us sort of consider why we didn't see any of this sort of correlation with socioeconomic disadvantage. And we thought perhaps we had focused on we are focusing our analysis on the population of already high disadvantage, and we're comparing within these, looking at AMR. And perhaps we had, by doing that, we had masked the effect of AMR within this population. Can we go back one? And despite much effort through the Indigenous enumeration survey, the ABS is known to undercount the remote population, the highly mobile population, and the young population, which is essentially the population we're dealing with in Northern Australia. So really, these indexes are perhaps not the best measures of socioeconomic disadvantage. And we really need to consider how they are derived, and for future studies to be really looking at associations between AMR and some more specific measures of social inequalities. Next, please. So if we think about, as a summary, if we think about whether we could repurpose AMR surveillance to capture the causes of the causes, as Michael Mermet would say, well, I think it's really important to interrogate the data and to really understand whether it is representative of the population. And then once we've really understood the data and how it's collected and how represented it is, then it's that sort of interoperability between the surveillance systems, which I think is doable, but it is a challenge. Really, the purpose of the sort of broader aim that we're trying to get at here is to develop a unified visualization platform that will allow us to connect the health, the demographic, and the sort of social deprivation data. And this was really just very much an exploratory first step in trying to see whether some of the administrative data sets could support in this sort of combination of different socio-economic drivers of AMR. But I think, this sort of work would really support the shaping of some of the public health policies so that people can, health policymakers that decide on which antibiotics are sent to which clinics can be informed by the right information, and to make sure that people living in remote and regional communities who might have access to good AMS and might have access to the right choice of antibiotics actually have access to the antibiotic itself. And this sort of work is important for evidence-based decision making. And it will support the development of machine learning and some of the clinical decision support tools, which are very much important and needed, particularly in resource-poor settings such as Northern Australia. Next, please. Just wanted to say thank you. The work was funded by Hot North and PRISM seed funding. Karin is the infectious diseases modeler that worked on this, Will Cunningham and Katie Ledingham, who is a UK-based social scientist and was part of the team. Thank you.
Thanks, Mignon. Sorry.
That's all right.
I've actually got half a migraine, everyone, which is why I'm a bit vagued out. Thanks, Teresa. Thanks. So we're jumping from Brian and deliberately going to Ruby, because Ruby Bison's going to be talking to us about our improvement work in primary care. And there are obviously some similar themes in how we can utilise the data in the primary care environment to improve prescribing. So thanks, Ruby.
Am I showing the right screen?
No.
Okay, I will. Is this the right
just switch
screen?
To present.
Is this the right screen?
Perfect, perfect.
Yeah. Okay, so I'll just share my video so you can see who I am. Okay. Look, thanks, Cass, for that introduction. So I'm a research fellow from the Department of General Practice, and we've been working a lot with NCAS as well. So on behalf of the team, the research team, I'd like to present some of our antimicrobial stewardship work, in particular a recent study on evaluating the implementation of a pilot quality improvement program to support appropriate antimicrobials prescribing in general practice. And if anyone in the audience are great with acronym, please let me know. So in the past 3 to 4 years, we have developed a program of work aimed to promote antimicrobial appropriate antibiotic prescribing in general practice. So we started off with an exploratory study with 28 GPs from 5 general practices that we want to understand how GP use electronic medical records and guidelines to make antibiotic prescribing decisions. So the study showed that GPs experience patient factors, ease of access, cost of guidelines can contribute to inappropriate antibiotic prescribing. So we recommended that therapeutic guidelines should be made available, accessible, and with minimum cost to practicing GPs. In addition, integration of evidence-based antibiotic guidelines within the electronic medical record in the form of a clinical decision support tool could also optimise guideline use and increase guidelines concordance prescribing. Around the same time, we conducted a pilot study called GP NAPS, which is part of the NAPS program that NCAS has, but we specifically concentrated in general practice. So the study was conducted across 11 practices in the east coast of Australia. We collected a total of 572 prescriptions and provided feedback report and educational seminars to all these participating GPs. Overall, we found that 39% of the total prescriptions were assessed as inappropriate. Therefore, we really need to encourage our GPs to prescribe therapies that aligns with therapeutic guideline recommendations. So embedding guidelines into the electronic medical record can increase antibiotic prescribing, appropriate prescribing. So the outcomes from the first 2 studies led us to the next 2 studies. So we co-designed with 10 GPs to develop a clinical decision support tool and to incorporate the therapeutic guidelines into the electronic medical record. And then we conducted a simulation study with 8 GPs using 2 clinical cases to assess the acceptability and the usability of the clinical decision support tool. So what we did was we brought together these studies to develop an antimicrobial stewardship quality improvement program. So we named it Guidance GP, and then we piloted these across 3 general practices in metropolitan Melbourne. But I also want to say that we, in addition to these AMS projects, we have co-designed patient information resources for 7 common conditions, and we piloted this across 8 general practices in Victoria, and we evaluated the acceptance of these resources, and they were there to encourage GPs and patient discussions and interaction to reduce inappropriate antibiotic prescribing and use. But for the purpose of this presentation, I want to go through the results from the pilot quality improvement program that combines an audit and feedback component and clinical decision support tool to facilitate access to therapeutic guidelines. So 31 GPs participated across the 3 general practices in metropolitan Melbourne. So the 3 practices range from 5 GPs to 21 GPs that participated in the study. And the pilot program consists of a baseline audit, which is GP NAPS, and prescribe antimicrobials using a 2-week period. So if the GP didn't put in the reason for prescription before closing the patient record, a little audit pop-up tool will come up prompting the GPs to put in a reason for prescription. The data were collected, analysed, and a feedback report was provided to these to each practice, followed by a webinar to discuss their audit results. And then this is followed by the implementation of the clinical decision support tool and the quality support, improvement support that was provided by the local primary health network. And GP NAPS audit was followed up 2 weeks after the intervention. So the whole process was across 9 months. So we collected data looking at the number of antimicrobial prescriptions and the proportion of prescriptions that were considered appropriate. And we also looked at whether it was compliance with therapeutic guidelines. So we also conducted focus group with GPs and interviews with practice managers to explore the acceptability, usabilities, and any barriers and facilitators of the program and their GP participation. We also looked at the feedback from the quality improvement activities that was undertaken by the PHN, the Primary Health Network, and the completion of the program provided all participating GPs their 40 CPD points. So apologise for this slide, it looks a little bit crowded, but all I really wanted to do is show you what the feedback report looked like. So we actually tailored this for each practice, comparing the overall practices to include the prescription numbers, the common indications, the prescribed antibiotics, compliance and appropriateness of prescribing. We also included general comments on what was done well and what could be improved on. So even though the number of prescriptions was not the goal of the study, it provided some interesting data. So at baseline, there were 231 prescriptions across 3 practices, compared with 72 prescriptions in the follow-up audit. Inappropriate prescribing was similar across both periods at 33% and 36% in 2020. So here we show the top 3 common indications and prescribed antibiotics during the 2 audit periods. So I just want to point out at this stage that the overall numbers were small. The audit period were not the same across the 2 years, and also the pandemic would have played a part in the reduced number of prescriptions shown in the follow-up audit. So during the focus group and interviews, there was 3 main take-home messages. So while GPs all thought that antimicrobial stewardship programs were important, they were concerned that the data would be used against them if they didn't prescribe according to guidelines. The implementation of the clinical decision support tool posed issues for the practice, as the tool needed to be installed on every participating GP's computer, so it became impossible during the lockdown period in 2019. However, having a practice champion such as the practice manager in the study was considered an enabler to the implementation process. So as the result of participating in the program, GPs mentioned a few changes, and these include having default settings to ensure reasonable antibiotic use is completed, and provide easy access to guidelines to ensure that guidelines are used more regularly, and offer follow-up and delay prescription options. In terms of change in prescribing, that can include stricter use of dates and limiting medication quantity, and removing default repeats in the electronic medical record. And of course, we should always continue to provide patient education and handouts for conditions that do not require antibiotics. It should be more visible places to put the patient posters in, especially in clinic waiting rooms, for patients to visualise and read about appropriate antibiotic prescribing, and trying to limit unnecessary antibiotic prescriptions. So the study was published in the journal Antibiotics in August this year. So where do we want to go from here? So we can look at taking this work into scale. So conduct a 2 randomised controlled trial across Victoria, or even in Australia nationally. However, since appropriateness is currently assessed manually, this is really, really insufficient. So we need to look at machine learning and to optimise prescription assessment. So we can also utilise ECHO, which stands for Extension for Community Healthcare Outcomes methodology for feedback sessions. So the ECHO methodology provides didactic learning where the GPs and practices can learn from each other. So similar to hospital NAPs, we can look at providing interactive platforms so GPs can look at their own prescribing data and benchmarking against peers in similar practices. So thank you very much.
Thanks, Ruby. We really do want to progress this work because it was very innovative and really exciting to do. So the last case study is something that I'm actually personally involved in, and it's actually really exciting. So I'm introducing Karin Butters, who's one of my PhD fellows with Gab Häusler. He's actually based remotely in Newcastle, but he's doing a PhD at the Children's. And this is our new world of looking in embedded randomised trials. So in our learning health system environment, if we can test interventions using an EMR, this is one of the ways we're going to be doing it. And it's no easy feat, as Cohen's probably going to outline to you. So welcome, Cohen, and I'm sure all of you will find this really fascinating.
Thanks very much, Kaz. I'm hoping you can see my slides now. I'm never 100% sure when I start. Fantastic. So I'm presenting today talking about embedding clinical trials in the electronic medical record and some of the learnings around that, and how we're applying this methodology to hopefully improve antimicrobial prescribing in a tertiary children's hospital. And as Kaz has highlighted, the fact I'm running a randomised clinical trial from Newcastle in Victoria just shows the way that technology is helping us to answer important clinical questions. So I just wanted to start by acknowledging that I'm supported by an Australian Commonwealth Government Research Training Scholarship, and also to acknowledge the fantastic support I've had from my 4 PhD supervisors through Royal Children's Hospital, Peter McMullen Cancer Centre, as well as Murdoch Children's Research Institute. So to provide some background, there's been a fantastic diversity of presentations today, and we're really going to focus down on febrile neutropenia and supportive care in children with cancer. And a lot of research regarding children's cancer is really focused on the curative endpoint. But actually, when you step back and look at all the aspects that get a child to cure, there's all these complex aspects of supportive care. And we think about things like blood products, nausea management, psychosocial support. But there's a crucial role for antimicrobial stewardship, treatment of infection, and diagnosis of infection. And it's these aspects that I'm particularly interested in, and our research team is interested in. It's important to recognise that febrile neutropenia is, if not the most common, the second most common complication of childhood cancer treatment. And over a child's 1 to 2 year cancer journey, they have cumulative antibiotic exposure, but that's not without harms. So there's the antibiotic side effects, and that might be reduced quality of life from nausea or antibiotic associated diarrhea or kidney injury. But then there's added antimicrobial resistance, and we know over a child's cancer journey that they accumulate resistance, and that itself is a risk factor for death. And then there's C. difficile infection, cost to the individual and society, particularly in terms of prolonged hospital admission, disruption of schooling, disruption of families. And then there's these complex unknowns in terms of the disruption of the patient microbiome associated particularly with antibiotic use, and increasing evidence in terms of how that might affect their response to future cancer therapy and indeed bone marrow transplant down the track. So common to all aspects of antimicrobial stewardship, we come back to these common questions: when to start, what antibiotic, and when to stop. And we have some pretty good answers to those first 2 questions. So through Gab's work and Karin's work and work of others, the idea of an important risk-based strategy using validated tools, as well as new microbiological techniques to define infection and hopefully define non-infection and stopping antibiotics early. Utilising biomarkers and point of care testing to guide treatment duration, as well as increasing use of fluoroquinolone prophylaxis, which is a controversial area, but in the first place, reducing episodes of febrile neutropenia and future exposure to broad spectrum antibiotics. And then we've been able to answer questions about what antibiotic, and there's general preference for broad spectrum anti-pseudomonal antibiotics, but also a movement to short course home-based care, as well as oral treatment in some studies. But then, particularly in the high-risk group, there's still this unanswered question of when it's safe to stop in children who are clinically stable and have negative blood cultures. Is that at a time of neutrophil recovery? Is that at a time when the clinician feels that there's clinical recovery? Or could we use biomarkers to really guide that? If we look at prospective collected data, and this is some of the work that Gab Houser's been doing in terms of the PICNIC study nationally, importantly, rates of primary true bloodstream infection vary across groups, but even in the high risk groups have reduced dramatically with tailored chemotherapy and approaches to other aspects of supportive care. When you look at intensive care admission for any reason, it runs at around 1 to 5%. And when you look deeper into that data, the reasons for intensive care admission are rarely for organ support, ventilation, hemodialysis, And overall, fortunately, we're in a position in which the mortality, 30-day mortality from febrile neutropenia is extremely low. Having said that, the median antibiotic duration in some groups is as long as 14 days. And that reflects the conflicting evidence. So there's a real tension between international guidelines, reflecting a paucity of evidence, between recommendations that suggest continuing simply until patients are afebrile for 48 hours and clinically stable, and other guidelines that are still recommending continuing until bone marrow recovery, which in many of these patients is 2 to 3 weeks with significant, potentially unnecessary antibiotic exposure. So as the duration of antibiotics is whittled away across other conditions and syndromes, we're really interested in what is the optimal and safe duration for clinically stable children with febrile neutropenia. In terms of the approach to this, we've taken a novel approach, and we're really interested in harnessing the power of the electronic medical record and adopting an embedded trials approach. To touch on what an embedded clinical trial is, a lot of it is captured in the name, but an embedded and pragmatic often go together. These trials are designed to bridge clinical care and research. And the 3 key aspects are that they're clinical, so their intent is at the end of that to inform clinical practice and drive clinical practice change. That they're generalizable, so that you enroll a real-world population that's representative of clinical practice, and that they're simple. So by using the electronic medical record, you're able to streamline procedures, streamline data collection. Ultimately, there should be no research staff, and that's what we're trying to work towards, and that this is part of the clinical care that's happening at the bedside. So when we look at the different components of embedded clinical trials, there's the importance of co-design is essential, and that the stakeholders have input from the outset in terms of design of the trial so that it's practical and can be incorporated into their routine clinical workflow. That you're able to work with EMR analysts to utilise the electronic health record to capture data routinely. That the study population is diverse and representative of the clinical question you're trying to answer, and that at the very outset that the outcomes you're measuring are important to decision makers to introduce change. There's certainly some benefits in other embedded clinical trials that have been run throughout the world. So importantly, that by embedding them into routine clinical practice, there's less infrastructure, staff, and there has been some small studies looking at cost-benefit analysis. There's less complexity for clinicians. There's more timely development of evidence and then translation into clinical practice, and you're able to provide research in a more representative population. The limitations are at this stage that there's limited experience to date because the aspects of clinical care are not protocolized. It's vulnerable to changes in clinical care, and we've had experience in that as part of this study. You are limited by the data collection capacity of the electronic health record. Because it's embedded within one type of electronic medical record, you can't routinely apply that in another EMR setting. And as we also found, the regulatory and ethical framework is complicated around this, and people generally are still coming to terms with how an embedded clinical trial, the storage of data, storage and transmission of data is managed. But there are, of course, good examples already of embedded clinical trials, and one of those is the recovery trial, which was an embedded clinical trial that really highlighted, despite Donald Trump's heartfelt belief that actually hydroxychloroquine is not an ideal treatment for COVID-19 infection. So the early versus late stopping of antibiotics in febrile neutropenia is a bit of a mouthful, but ELSA FN is a randomised clinical control trial that's embedded in clinical care at the Royal Children's Hospital. And this study is set up to determine the non-inferiority of stopping antibiotics prior to absolute neutrophil recovery in afebrile clinically stable children with high-risk febrile neutropenia. And we'll be looking at safety, in particular aspects of physiological instability, readmission to intensive care, but also looking at the impacts of short-course antibiotics on duration of neutropenia, antibiotic days, length of stay, C. diff infection, antimicrobial resistance. We'll also be looking alongside that at clinician confidence in doing that and acceptability to patients and children of this approach. This slide looks at our workflow. We can see here patients are admitted to Royal Children's Hospital. The electronic and medical record is recruited to identify patients that are considered to have high risk for febrile neutropenia. This triggers consent at the clinician end, and consent is fully electronic, with the families scanning a QR code and signing the consent form, which is emailed back to the researcher. At some stage, and that could be in the middle of the night, the electronic medical record acknowledges that a patient meets all the inclusion criteria and none of the exclusion criteria, and randomization is triggered. And then at that point, the clinician at the end point sees the randomization point and is told to carry out the intervention, in this case, in this stopping antibiotics. And at that point, we utilize the electronic medical record to collect that data. So this has been a really insightful process in terms of how you design, how you utilize an electronic medical record to capture this kind of data. And this is exciting because the initial cost of introducing EPIC, the electronic medical record at Royal Children's Hospital, was $50 million. And part of the idea of introducing this was that this could be harnessed for research, that clinical care, antimicrobial stewardship, research could be conducted at the bedside. And we've never been able to get that along the over the line. So we're interested in this as a proof of concept. So in the initial consultation phase with our EMR team, there was a particular focus on what the EMR can and can't do. And we identified, for example, that the EMR had never been utilised to randomise patients, and that's something that has been overcome in the last couple of weeks. It was essential to have consultation and co-design with the people who were end users, and we conducted a number of focus sessions with consultants through to junior medical staff to see how they actually conducted their ward round workflow. Then we entered into a build phase with the health informatics team to look at storage and collection of data. And we're now just completed the testing phase. And I'm really excited to say we're now in the active monitoring phase with the initial consent and recruitment of patients last week, which timed nicely with the National Antimicrobial Stewardship Week. And then I think we're likely to enter into a phase of redesign as we discover that parts of this EMR design just don't work well, or that we may not be recruiting patients as actively as we might have liked. So in terms of our learnings at this point, in terms of running this trial, we don't have actual data already, as we've only just recruited our first patients, but we've discovered a number of things about it embedded in clinical trials. So there are some huge advantages. So the fact that I can sit in Newcastle and watch patients being recruited and consented and randomised is a huge advantage, I think, and is a way forward for research, and even in remote areas, for example. There already there's no research staff, and I think despite the initial setup costs, overall it's likely that this will be a cost-effective approach. There's been incredibly strong clinician engagement, I think, because this is a paperless trial and it's happening at the bedside. There's real excitement about this. People are interested, of course, in how they can use this methodology for their patients. There's integrated adverse event reporting so that we can get into a patient's file and attribute trial-related events actively as they occur. We're also going to be able to adopt the learnings from this methodology to future trials. And because the innovative approach in the initial aspect to the embedded aspect, it's driven innovation throughout the entire trial by taking this approach. There's also, of course, some challenges. So translating a written trial protocol in terms of electronic medical record design has probably taken 4 to 5 months. The integration of randomization has proven to be tricky. We've also had to be careful to match our clinical trial design with clinician and EMR workflow. We've also had to think about pop-up design, the best practice advisories, and how to ensure that they don't interrupt patient workflow and to ensure that they're still focused on meeting patient safety requirements. And then actually identifying patients from the electronic medical record who meet inclusion criteria, identifying their phase of treatment, identifying clinical stability, and extracting microbiology from the electronic medical record has been quite tricky at times. And then what we still don't know is the quality of the data output and how much data cleaning is going to need to be done at the other end of this. And now as we enter into or come out of the testing phase and we're actively recruiting patients, there's a number of unknowns and there's still a nervousness around the team about how well this is going to work at identifying actively recruiting patients. So in the conclusions at this stage of the trial of ELSA-FN, we know that prolonged antibiotics in children with cancer have a range of potential harms. Current evidence to guide antibiotic duration in children with high-risk febrile neutropenia is limited, and international clinical practice guidelines provide conflicting recommendations. This is the first study of its kind, and by using a novel embedded trial design, we're hoping that we're able to inform the optimal duration of antibiotics in febrile neutropenia and hopefully reduce antibiotic exposure in this population. And I hope that I've highlighted how embedded pragmatic trials can potentially be used, and hopefully that this is able to provide cost-effective evidence to inform antibiotic microbial stewardship and to guide interventions in the future.
Thanks, Karin. And when he says it's been quite complicated, I can honestly say that there's been several hundred hours, I think, correct, Karin?
That's correct.
Yes.
That's correct.
All right. So I think we're running short on time, so we won't have time for Q&As. But please feel free to reach out to any of us specifically. It's really important for us to reflect, first of all, the importance of the Commission and their role in setting our standards and monitoring them. So I'm really happy to have Fiona Dukas today presenting with our NAPS team on how we can make sure that our auditing tools are fit for purpose, particularly around the clinical care standards. So I'm actually going to hand over to Rod James, who's our program lead for NAPS, to run this session. So thanks very much, Rod.
Sorry, Kaz, I'll just jump in. It's going to be Sin.
And Rod was going to run it, I think.
So, yep.
Sin's going to talk. No, Fiona's going to talk, and then I can't remember which way around, but Rod's going to share it, I think.
Okay, I'll just...
Karin, do you want to stop sharing your slides?
Thank you. Yeah, I can't share, thank you, but I will now. Okay, so my video was working earlier, but it's not at the moment. So hopefully that starts. If not, can you hear me?
Yeah.
Yeah, and Arjun, can you make Rod a panelist, please?
I just did, yeah. Thanks, thanks, Kaz. Sorry about that. I assumed Sin would be speaking and then Fiona. So, yep, Rod is now a panelist.
Thanks, everyone.
Okay, so I'll be starting first, and then I'll hand over to Zin. So welcome, my name is Fiona Dukas. I was an AMS pharmacist for many years, and I'm currently a senior project officer at the Commission, developing and reviewing clinical care standards. So I just want to talk about what is a clinical care standard, its place in terms of hospital accreditation, and we're launching today a monitoring tool for our Antimicrobial Stewardship clinical care standard, which I'll show you. Talk about the process of the update of that standard, and then talk about some upcoming ones. The more recent one will be sepsis, and then potentially COPD next year. So what is a clinical care standard in the Commission? So the Commission's a body that was formed in collaborative with all the states and territories and the federal health government. So an independent authority under the National Health Reforms Act to promote quality and safety in healthcare. Nationally, we're probably famously known for the hospital accreditation standards, which have now branched into a range of other areas. AURA as the Antimicrobial Use and Resistance in Australia program, and we developed the Atlas amongst lots of other work. And underneath the national standards, the clinical care standards program sits, and all day procedure centres and acute health service organisations are required to meet the standards of the clinical care standards, but antimicrobial stewardship specifically is uniquely identified as something that's required to be met, and Jason Trubiano showed an example of that in his talk. So clinical care standards, they're different to practice guidelines. They don't prescribe which antimicrobials to use, for example, but they describe the care that all patients across Australia should be offered, regardless of their location, the patient cohort, if they're a neonate or an adult, which parts of Australia they're in, whether they're in a tertiary teaching hospital or a remote hospital, or a day procedure centre, as I mentioned. So you'll see that the terminology is around a patient should be offered, or etc. And associated with these quality statements are indicators that allow health service organisations to monitor how they're performing. So we start off by looking for the evidence gaps and variation in practice across the country, and any potential safety and quality issues, which may come from things like I mentioned, the Atlas publication, or a priority from the Senate, the Australian Health Department, Greg Hunt, something like that, that defines that there's a need for a clinical care standard. Then we go around discussing with many key stakeholders, clinicians, consumers, quality managers, states and territories, about what are the key components of care or priority focus that we would expect all Australians to receive for this topic. And it's to try and reduce variation, but we also look at what guidelines are available internationally and nationally, and the goal is to improve patient outcomes. And then we write those quality statements and their indicators that we hope are actionable, measurable, implementable, and describe who, what, and when should be elected. And so these indicators are the tools for local health services and AMS programs to monitor the implementation. And they really are supporting local quality improvement. And you can collect those from a range of ways. And Zin will talk about NAPs, but might be around from your AMS audit and feedback rounds. It might be from, we heard about electronic medical record alerts, or data collection tools. It might be a range of things that you're collecting that could be fed into the indicators. And also, like I said, this is the minimum standard that we expect health service organisations to have. But if you have a mature AMS program, you may be collecting these and other things. So not to say that you can't collect it in addition to that as well. And a question that we really commonly get asked is why there are no benchmarks or targets, which we do not set. And that's because the goal, we don't collect the data ourselves as the Commission. It's collected locally by the health service organisations or the states and territories. And you might have a different goal to another organisation because you might be doing particularly well in one indicator, or you might have a long way to go. So just acknowledging that, and that's a commonly asked question. And like I said, we try to make sure that these are valid and evidence-based and applicable to a range of settings and defining their actions. Something that often gets confusing as well is how to find all the attributes or the specifications of the indicators. And while we have a web page, the Federal Health Department has a website called Meteor, which is the metadata online registry, which has a range of indicators. So all the specifications are actually, you have to take one more click and get into the Meteor website for all those specifications, because they're the most current and up-to-date version with all the content in them. And that looks not very visually attractive, but that's what it looks like on the screen. And like I mentioned, you may be collecting other things, and we also recommend you might be looking at hospital-acquired complications, patient experience, and patient-reported outcome measures in addition to the indicators. So we updated the AMS clinical care standard in November 2020, nearly 1 year ago. And from the 1st of January, that 2020 version will be the only version available to you. The 2014, the first version will be rescinded. Earlier this year, the National Safety and Quality in Health standards for accreditation were updated, and the number for antimicrobial stewardship shifted because there's a few COVID additions. But you can see that it's particularly outlined that the antimicrobial stewardship clinical care standards core elements and recommendations and principles are used, but also that, which is relevant to the title of this overarching talk, that the actions of results on audits are used to promote continuous quality improvement, and that organisations are using this data to support prescribing appropriately and to evaluate their performance and to report these findings to clinicians and governing bodies. And one way that we hope to help you and save you time, especially if you don't have strong IT support as part of your AMS program, is that we've developed, and like I said, launched it this week, the Antimicrobial Stewardship Clinical Care Standard Indicator Monitoring Tool, which essentially is an Excel spreadsheet where you can input data repository and analyze it, and it generates visually appealing reports that you can present to your AMS team, clinicians, or executive. And I've put the website there for you. And like I said, it helps you process the indicators from the standard to examine the results and identify targets for your organisation's improvement. It can help you meet the standards, and you can also set your own benchmarks locally if something like a statewide AMS program or a local health network or district, or even just your own hospital. And so I was asked to talk about how standards are updated. So the AMS clinical care standard underwent a review last year. So as I mentioned, there's a review of all the current evidence base to date, initial engagement with stakeholders from a local level up to a national and state and territory level, the standards drafted and or updated, and then establish a topic working group, which has a range of people from primary care, tertiary care, specialising in infectious diseases, or other areas that paediatrics and adult population, people with an interest in data, who get together, review the content and discuss the evidence. And then a second draft was developed in this case because it was an update. But if this was a new standard such as sepsis, we've had at least 4 meetings to date. But once an agreed final version is created, it goes to organisations to endorse, and professional organisations as well as the jurisdictions. And then we also analyse all that feedback that we get and finalise the resources. So there were a few changes, which I'm not going to go into because they're up on the webpage in the interest of time. But like I said, so it was discussed around, there was a new quality statement around adverse reactions to antimicrobials, and the sepsis indicator was retired because it will be moving to the sepsis clinical care standard. And there was a number of other changes, which are visually represented for you there. I mentioned that there is a sepsis clinical care standard, so thank you to anyone who provided public consultation feedback on that version in August and September. I just was going to give you a taste of what was there because it's not available, but there's some quality statements around recognition, time critical treatment, the management of antimicrobial therapy, escalation of care, around multidisciplinary coordination of care, some patient information and education, documentation and at the transition of care, as well as survivorship and what happens post-discharge. So this was a deliverable under the National Sepsis Program, and which has a range of other activities, and there was strong support from the public consultation for this work. So the plan is now to finalise the standard with the goal to release that in June of 2022. So just thank you to everybody, including the topic working group members, of which there's a few people here, the standards team, and anyone who provided feedback or has endorsed the standards. And I'll hand over to Zin.
Thank you, Fiona. Just going to share my screen. Can you all see that all right? Is that all good?
That's a great scene.
Perfect, thank you. Good afternoon, everybody. So for my part of the talk, I'm gonna have a chat about the National Antimicrobial Prescribing Survey and give that a bit of a comparison against the clinical care standards. So I'm going to talk about which part of the NAPs align well with the clinical care standards and which are the areas that we have identified as areas for improvement. And I'll bring you up to date with the discussions and meetings we've had with the Commission and with the Commonwealth to talk about how we can upgrade and improve the NAPs in the future to make sure that they're more aligned. And this is largely from feedbacks we had from our users as well. It will be very useful for you to just use one auditing tool and to be able to do your NAPs as well as cover most of the clinical care standard, if not all of it. All right, so this is just what Fiona has covered in her talk. So the 8 quality statements. And in this slide here, I've categorized them into 3 sections. So we've got the green ones here. So this is part of the standards that we believe NAPS in its current form covers pretty well. So for example, use of guidelines. If you've completed the NAPS survey previously, you would know that for each of the prescription, a user is required to assess it against either the TG or the local guideline. The data is then input into the portal and you can do reporting and benchmarking on it. Same as documentations of indications and stop and review dates is fairly well covered by the NAPS, as well as surgical and procedural prophylaxis is being covered quite extensively by the surgical NAPS module. Then we've got this section, this gray section here, which is life-threatening conditions and patient information, so and shared decision making. So these are absolutely essential, but it just doesn't align terribly well with the purpose of the NAPS right now. That's not to say that in the future we're not gonna look into this, but this is not something that we're looking at building in the short term. So that takes us to this section here in the middle, which is adverse reactions to antimicrobials. And Fiona mentioned in her talk, this is the new standard that's recently introduced last year, as well as microbiological testing and review of therapy. So those 3 were identified to be areas NAPS are not currently covering it comprehensively. However, maybe changes can be made to make sure we're more aligned with this. So I'm going to go into each of this and briefly talk about some of the challenges and considerations. So we'll start with ADR. So this refers to if a patient has an ADR that's reported, the active ingredients, date, nature, and severity of the reaction should be assessed and documented. So they are really 4 components that's essential here. And Jason covered this quite a fair bit in his talk as well. So what are some of the challenges? When we say severity, clinicians would know this very well. When you talk about minor, moderate, severe reactions, you're largely doing a bit of guesswork there. There's no readily available sort of definition that's well accepted. So it's a bit hard to define that. One other challenge in building this into the NAPS is when we're looking at the denominator, which is outlined in the indicator section Fiona talked about. When you're looking at the indicator, part of that is the definition of the denominator. That for this particular standard is all your patients that has a ADR towards antimicrobials. But if you think about the NAPS methodology, we only include patients that's currently on antimicrobials. Therefore, that denominator becomes patients on antimicrobials and having ADRs towards antimicrobials. So there is a slight difference there that needs to be considered. So some of the other considerations, how do we deal with partial documentation? So an example would be you've got a patient and reported to have 4 ADRs towards antimicrobials. 3 out of 4 had really good documentation. Let's just say name, date, nature, severity, all very well documented. The 4th one is largely covered, but let's just say the name is not a generic name. Would you then assess that as incomplete, essentially the same as a really dodgy sort of documentation with no information, just the drug's name? So it feels like there needs to be some nuance to differentiate those 2 patients. So another suggestion that has been made is when we're building this, instead of trying to cover all the antimicrobials to start with, maybe we should just focus on a class that is the most important and relevant. So this is one of Jason's suggestions. Maybe we can look at just penicillins or beta-lactams to start with to do that well, and then consider expanding it to other antimicrobial classes. And we also talked about maybe we can build a separate module, like an allergy NAPS module, as opposed to another option would be building a conditional field in the NAPS, where it appears if a user indicates there is an ADR towards antimicrobial, then a set of questions regarding to the nature of the ADR then appears. All right, so moving on to microbiological testing. So a patient with a suspected infection has appropriate samples taken for microbiology testing as clinically indicated, preferably before starting antimicrobial therapy. So some of the challenges, so we know that the way NAPS set out right now, it goes by the antimicrobial, not the indication. This might change in the future, but right now, obviously microbiological testing goes with the indication. So if a person is on multiple antimicrobials for one indication, we need to think of the way to avoid the user having to duplicate that data for each of the antimicrobials. And once again, how do we deal with incomplete collections? So if there were multiple testing that's indicated, and if it's largely completed versus, it's just not completed at all or not in a timely fashion, maybe there needs to be a way to differentiate that. And another major consideration is when we're talking about microbiological testing, it's so much more relevant to indications like sepsis, meningitis, endocarditis, as opposed to something that's like appendicitis. So really, it almost needs to be a conditional field that only appears when relevant indications are entered. And that brings us to the third one, which is review of therapy. So this refers to whether antimicrobial is prescribed, and depending on the indication, the patient acuity and risk factors, the ongoing use, the spectrum, the dose, frequency, and route should be assessed and adjusted accordingly. And it's recommended that this should be done round about the 48-hour, 2 to 3 days mark. So some of the challenges with incorporating this into the NAPS, once again, indication versus antimicrobial, we want to make sure that the user don't have to duplicate this entry for each of the antimicrobials if multiple antimicrobials were prescribed for one indication. So this review of therapy only applies to certain therapies. So that's things like short-term empirical and initial treatment. So if you think about if somebody has been on a Fluclox for 6 weeks for a Staph aureus osteomyelitis, when you're well into that therapy, this review probably isn't as indicated as something that you just started for empirical therapy. And we know that based on previous NAPS data, majority of our patients included in the NAPS are audited before they have had 48 hours of therapy. Therefore, the review of therapy is probably not terribly suitable for this class of patients because they're so early on into their therapy. We need to know the start date of the antimicrobial to determine when is a good time, like has the patient been reviewed. So the start date of the antimicrobial is essential. It's not compulsory in the NAPS right now. However, this is something we can easily change. So some of the other considerations, when we talk about review of therapy, what do we mean by review? So outlined in that indicators site, review is by a prescriber, and it should consider the need for ongoing therapy, the spectrum, dose, frequency, and route. So if we think about this, it's very unlikely you're going to rate somebody's medical record and the treating team is going to say, we reviewed these antibiotics and we reviewed all those aspects of it. Like, it's not common practice. So we need to think about what if there's only a little bit of a comment in the medical record about the dose? What do we make an assumption about the rest of those components? How do we deal with what we can probably call a partial review? And also, what we see very commonly in practice is somebody wrote, largely probably the junior doctor wrote continuing antibiotics in the ward round. What does continuing antibiotics mean? It can mean so many things. It could be as simple as the team came around, had a look at the patient didn't really change much, and they went, okay, everything go as per normal, and the intern documented that. Alternatively, the team would have came over, would have reviewed the antibiotics completely and comprehensively, had a chat about many different aspects, probably potentially contacted ID and had a 30 minutes conversation about it, but the decision was to continue antibiotics, and that is what's being documented. So there's a lot of nuances that goes into this continuing antibiotics. And the last thing we probably need to consider for incorporating this is the escalation and de-escalation of therapy. Do we treat that the same as the initial treatment and subjected to the same level of review that's required? So that is also a decision that's to be made. So that pretty much takes me to the end of this little section. So hopefully I've made it pretty clear that as much as we wish to just build a additional tick box in the NAPS that says, is the patient reviewed, or has the patient the ADR documented, is really not as easy as just building the tick box. So a lot of thought has gone into this, and we're still gonna continue this discussion with the Commission and the Commonwealth Government. And once we've got a clear plan, we'll then go ahead and secure fundings and resources, and then changes will need to be made to the data entry portal, as well as calculations, reporting, benchmarking that goes into all the background development before we can bring this to you guys and deploy it to the current NAPS website. We definitely welcome any sort of suggestions or comments. Please feel free to raise it here, as well as you can always shoot us an email or give us a call to let us know what you think, or what you think might potentially work, or that's important for your facility. Thank you very much.
Thank you both, Fiona and Sin, for that very informative presentation. It's good to see that we are moving forward with the clinical care standards. I think it's excellent work. We know from the NCAS point of view that since the clinical care standards have been in place, there's been a lot more interest in antimicrobial prescribing, and I do think the new clinical care standards actually provide more information, more guidance around what is required from an antimicrobial script. I wish the general practitioners would follow these, and to make our general practice NAPS a lot more easy to perform, and there's actually data available when they don't even put a reason for prescribing in is quite appalling. And I hope we can, with these clinical care standards, improve prescribing in Australia. And as Sin has kind of demonstrated as well, we are working towards trying to get a more robust auditing program with the limitations of a point prevalence survey. But of course, while you are auditing, it is best to audit as many of our clinical care standards as possible. So we will hopefully give some more information to you in the future. As we have kind of come to the end of our session, we probably will leave it for the time. Thanking everyone for their participation. There was a lot of speakers today, so I hope I don't forget anyone. Thank you very much, Jill Francis, for your amazing talk early on. For the case studies, Jason, Trubiano, Brendan McMullen, Mignon Avant, Teresa Wozniak, Brian Herr, Ruby Bison, Cohen Butters, and thank you again, Fiona and Sin, for your presentations. If anyone does have any questions, please forward them on to the NCAS. We can forward them directly to the speakers. I just guess in the last 5 minutes, if anyone does want to ask questions, particularly about the last two talks, while we have the presenters here, some of the other presenters have left already. We are more than happy to answer any questions and happy to stay online for 5 minutes or so. Otherwise, please send them through and we can answer those in order. So thanks, everyone. And hopefully we have a very good rest of the Antibiotic Awareness Week and weekend.
might just say that at the primary care, we're trying to engage them more and doing a fact sheet specifically targeted at general practitioners and community pharmacists. And I saw that Ruby said that she might want to collaborate. So might follow up with you, Ruby, as well.
The other good news is in our discussions with the medical director and a few of the other programs which the primary healthcare people work with, there is the ability to create a indication field which is compulsory, and that is not something they're adverse to doing. So in the future, it might be compulsory that all general practitioners have to put an indication for the antimicrobial before prescribing, which is excellent. Okay, well, I think there's been no major questions come up in the chat that I can see. So I think at this stage, I will close the session. Thank you, everyone, all our talkers and all our attendees, and we'll leave it there and have a good antibiotic awareness week. Thanks, everyone.